Welcome to our webinar and thank you for joining us today. So this is a 90-minute webinar to explore the complexities around oral intake in patients in prolonged disorder of consciousness. We've got three of us presenting today, myself, Amy Endicott, Dr. Amy Pundle and Erin Probert. We are three SLTs here from the team at the Royal Hospital for Neuro-disability in Putney. And we have a wide range of services for adults with complex neurodisability, including a level 1 brain injury unit, as well as long-term care placements. This webinar is being recorded and will be available on the RHND YouTube page in the near future. So today, we're going to whiz through a quick review of PDOC. We're going to talk about how and when we use oral intake for assessment of awareness in the PDOC cohort. We're going to discuss the emerging ethical and legal considerations within this patient group, reflect on a case study of a recent patient, and we will have time for questions at the end. So please do add questions in the chat box as we go, and we will collate these all together and try and discuss at the end if we have time. Okay, so a bit of a refresher on prolonged disorder of consciousness. So the operational definition of a prolonged disorder of consciousness is someone that remains in a low level of arousal for more than 4 weeks. And this arises from widespread brain damage and disruption to these brain networks. So it's important to start with an understanding of what consciousness is. So for consciousness, we need both wakefulness and awareness. And it's important that we don't conflate the two because they are different. So wakefulness is a state in which the eyes are open and there's a degree of motor arousal, contrasting with sleep. And awareness is the ability to have and the having of an experience of any kind. So PDOC is a spectrum and patients may progress through this in a more linear fashion. They may fluctuate between states or they may stay static with them remaining in vegetative state or minimally conscious state long term. At the lowest end of the spectrum, we've got somebody in a coma. So they've got no discernible sleep-wake cycle. The eyes are always closed and they're unresponsive. So basic reflexes like coughing and swallowing will be impaired and the person won't respond to any pain stimulus. Moving up, we move to vegetative state, which is a state of wakefulness without awareness, in which there's preserved capacity for some spontaneous kind of behaviors. And there's a sleep-wake cycle, but these behaviors are reflexive in nature, okay? So it's characterized by an absence of behavioral evidence for self or the environment. So behaviors are reflexive at the level of sensory processing. So this is when there's a loud noise and somebody jumps in response. Minimally conscious state is a state of severely altered consciousness in which minimal but clearly discernible behavioral evidence of the self or the environment is starting to be demonstrated. So this is where we see inconsistent but reproducible responses above the level of spontaneous or reflexive. So these responses will start to be localizing in nature. So for example, if there's a loud noise and the person turns towards the loud noise, they're starting to explore and understand what is happening in the space around them. And then emergence is the threshold where a person is no longer deemed to be in a disorder of consciousness and now consistently shows a discriminating level of awareness and understanding of themselves and the world around them. Now, there's a really big debate at the moment around emergence and what defines this, but the RCP define it as having consistent functional communication or consistent functional object use. However, we know there are lots of patients who aren't in a disorder of consciousness and are emerged, but do not meet the criteria due to physical, sensory, or linguistic impairments. And therefore, we need to be more dynamic in how we approach these patients, especially as we're experts in communication. So we need to use our clinical reasoning. And even when these emerged people start to interact and explore the world, they are still left with severe cognitive impairments. Okay, so this schematic is quite helpful in understanding just how impaired people in PDOC are and typically remain during their recovery and periods of stability. So these are the routes that we typically see. So as we said, even with our emerged patients, they tend to remain totally dependent for care and with severe cognitive problems. So lots of the decisions that we make will be in these people's best interests. Okay, so when we look at PDOC assessment, we consider normally three things. So the causation of the brain injury, the primary neurological pathways, and the behavioural assessment. And the behavioural assessment is really the cornerstone of PDOC assessment. So although these diagnoses of what level of PDOC a person is should be confirmed by an expert PDOC physician, as an MDT, we have a key part in gathering the relevant information to inform diagnosis. So as SLTs, our role is twofold. So it's important that we assess behavioural responses, but we also optimise communication if we can, and provide sensory stimulation. So lots of different assessments that we use. So we can see here in the orange box are the more formal assessments. And in the green box, we've got the more informal assessments. And we would do these as an MDT with a range of stimuli over a range of times and settings. So the more structured ones we have are the Coma Recovery Scale, the WIM, the Matadoc, which is a music-based assessment delivered by music therapists, and the SMART. And in the green box, we've got the Putney Personalised Programme, which is something we use here where we take individual kind of set tasks that challenge the highest behaviours, and then we repeat these frequently with the patient to offer kind of sensory stimulation and track change. We also use contextual and dynamic assessment, so context being perhaps observation with family or observation in another therapy session. And then we scaffold the patient up and down, dependent on how they're performing, so we can explore different modalities with them. And this is important because these will capture behaviours that may not be captured in the more formal assessments. So particularly with patients that are in a minimally conscious state, it would be really important that we assess in this way. And we might, oh dear, so let me just go forward. I lost where I am. Yeah, so these assessments, more informal ones, would capture things that aren't in the more standardized assessments, and that's really important. One thing that's really important is that in our assessments, we should make sure that we have clear kind of systematic documentation of behaviour. We can report on trajectory of change, as this is a real key prognostic indicator in PDOC. So talking about oral intake, exploring oral intake would fall under this contextual and dynamic assessment heading. And also important to say, just here we've put the guidelines for speech and language therapists, which is something that was developed with kind of expert SLTs working in this field. And this is something that's freely available online that may be helpful for people. Okay, so why would we consider oral trials? So oral trials are really helpful, as we said, for people that cannot demonstrate emergence through the current criteria. So someone with maybe very limited sensory input, and processing, severe physical impairments, language problems where they can't meet that functional object use or communication thresholds. It offers sensory stimulation as well, a really nice kind of functional method. Concerns around negative oral behaviour. So sometimes we see people that are kind of very orally aversive, and that might be because their experience to date has been around kind of rough oral care, potentially yanker suctioning, teeth brushing, and actually introducing something that might be pleasant might kind of act as a nice desensitization for those oral behaviours. Obviously, food and drink is very emotionally salient. It's a really big part of our lives. What do we do when we get together with our family and friends? We eat and drink, we talk about food and drink. So it's incredibly motivating. And of course, lots of us love our food. We're pre-morbid foodies would be how we'd be described. So something that's meaningful to the person, we know we get the best from the assessments. And the RCP does define oral feeding in PDOC as a part of sensory stimulation. So it's something we should be looking at. Okay, so how might we do it? So these are kind of the practical considerations and implementation of oral trials in people with PDOC. So this is different to how we might look at oral intake as speech therapists with a non-PDOC population, where we might go along, assess how they're doing, establish some oral intake, slowly grade it up. But here we need to consider things slightly differently, as this is an assessment block and the introduction of oral intake is not a given and it's not a kind of single discipline decision. So we've got here a little bit about the setup, obviously making sure that the person is optimized medically, that they're comfortable, that their trachea is being appropriately managed, any of their saliva is being managed. Think about the activity locations. So we talked about PDOC assessments should be happening in a range of settings to get a kind of breadth of what the person can or cannot do. So think about where you're going to try your oral intake. It's really important to know what the person likes, but equally, sometimes people respond more to things that they don't like. So it's not about giving anyone anything kind of really dangerous or really, really horrible, but provoking a kind of negative response can sometimes be quite good in eliciting behaviours. And think about the people involved. So You can involve other members of the MDT and family, but it's really important with this cohort that this oral intake and exploration of oral intake is overseen very closely by speech therapy and is speech therapy led. Think about your assessment period. So making sure that it's structured, that you've got a protocol so that you're repeating things. So you're giving the person the best chance to kind of learn or pick up what you're doing and show their behaviours. But equally, you need it to be repeated and structured so that you can plot any trajectory of change. It needs to be time bound because it's an assessment. It's not something that's a given that we're taking forward. So you might say, I'm going to do this 2 times a week for 3 weeks, and we're going to compare how they were at the start to the finish. Think about the task structure in the queue. So how are you going to scaffold them up and down? Different modalities. Are we thinking about, touch, taste, smell? All of those things are still relevant within oral intake. So what are their strengths? And use it as an educational opportunity. So misinterpretation of behaviours in PDOC is really common from family and other professionals. So make sure that you get them involved, observing and talk through what you're seeing. And again, documentation. So you may document it kind of through the PDOC SLT toolkit. There's an assessment sheet in there that we can use, just a behavioural checklist. But really the key thing is that you're looking for the trajectory, any kind of awareness and recognition that you see. Okay, so this is just a little bit about the continuum of responses that we see from people in vegetative state to minimally conscious state to emerging around food and drink. Now, certainly this is not kind of everything. There's a lot more. And I think it also happens within the wider context of other behaviours that you're seeing. But, in these really reflexive responses, we might see things like a gag, someone thrusting their tongue forward and backwards, bite reflexing, lip pursing when we approach them. In minimally conscious state, we might see someone starting to kind of differentiate between different things. They might be localizing towards what we're showing them. They might start to open their mouth in anticipation of the spoon. And then if they're emerging, we're looking more at choice making and kind of that lower level problem solving, seeking and initiating intake. And this is typically where we see people start to be able to manipulate solid food more. It's important to know about the different responses, but my other advice would be think about what the person does at rest, so that you can have a good comparison of what is happening at rest without any stimulus, and it's probably reflexive, and what is happening with stimulus, so is probably meaningful. Okay, so you've done your assessment period, and now you have to think about, okay, well, what is your assessment telling you? Where do we go next? So it's important to think about, okay, what is it adding? What is this not adding? So your pattern of responses, so is it purposeful what the person is doing? Where are their behaviours on this hierarchy? Are they reflexive, discriminating, differentiating? What's going on? A lot of very reflexive movements can be misinterpreted. So think of what you see when someone is sleeping. Okay, they're not cognitively thinking about what they're doing. They're not aware, but they have lots of reflexive behaviours that can be misinterpreted as eating and drinking. Think about their awareness and communication behaviours. Do they show increased communication or awareness with this task compared to others? Balance the risk and benefit. So risks of the pharyngeal swallow, risk due to poor positioning or medical instability. What is the true benefit that you can see in the moment? Are you just feeding a reflex? So a pharyngeal swallow is reflexive. If you can get gravity on your side, then you can very reflexively manage fluids or diet. So just because someone swallows a bolus does not mean that there is a level of cognitive processing. And then we have patients sometimes where, they are just very reflexively eating and drinking, but on first glance, it can actually look quite convincing. I had a patient who had a kind of rotating jaw movement, a really stereotyped movement of rotating the jaw and then opening the mouth. He'd twist his jaw kind of twice, then open his mouth. And the carers had got really good at just timing to feed him at that point. So it looked like he was opening his mouth to a spoon, but actually it's something he was just doing at rest anyway. So that's good. It's helpful to know about because that movement can be utilised for oral care, but utilising it for eating and drinking is very different. What's their trajectory of change? So is there an increasing breadth or complexity of behaviours seen during the task? Are they just engaging with it or are they enjoying it? What's the personal relevance of oral intake for that person? Was it something that was really, really important to them? Food and drink stimulus versus non-food, are they actually differentiating between them as two different things? That will tell you about whether they really understand whether this is food or drink and what the function of this stimulus is, and make sure you compare it with alternatives. So think about other things that we can be doing as well. But it's important that you think kind of critically about what the benefits are. The decision around this needs to be made as a team. So the same way with any interventional therapy, you would consider what the benefits or risks are. You wouldn't do it just because you can. So all of this needs to be considered within the bigger picture of the patient and their life moving forward. Especially as speech therapists now, we also need to consider the interplay of oral intake with life-sustaining treatments, which we will come on to. So finally, just thinking about alternatives to oral intake, if you don't think it's the right way to go for your patient, then Biozoom. Biozoom is really good. It's really easy to set up. It's got lots of positives around it. Okay, it's not the same as food and drink, but actually it can offer the same practice of the task. It can offer the same social inclusion, sensory stimulation, and it's obviously quite separate to oral intake. So there's a kind of a nice barrier between Biozoom and oral intake. Mouth care, toothbrushing, again, providing good sensory stimulation, keeping the mouth nice and clean. That will also help encourage kind of any further development or behaviours. Sensory stimulation, using principles from facial oral tract therapy, making sure the patient's in good alignment and getting them into the routine. And then you can see from there if anything develops. But it's really important that we consider whether oral intake or alternatives to oral intake are appropriate for that patient. Oh.
Hi, everybody. My name's Erin. I'm one of the clinical lead speech therapists here. Just a brief reminder before I crack on with my section that if you do have any questions about anything that we're talking about, just pop it in the chat. And then at the end, we'll have a chance to come back to some of those. Okay. So Amy's given us kind of an excellent overview there of decision making around sort of oral intake. What are we using it for? How are we using it in assessment? And what kind of alternatives there might be. But what do we do if from that assessment we've identified a patient who is in PDOC, but who we think has the potential for ongoing oral intake? So there will be those patients, as Amy's just referenced, who are dependent on largely reflexive behaviours. So although they are managing to swallow a bolus, it's dependent on their reflexive responses to the stimulus. They're not showing any sort of active engagement or participation within it. And for those patients, it might be that, you know, you're using your oral intake and your taste as part of your awareness assessment, and then that naturally comes to a stop at the point that you feel like you've established as a team what the diagnosis is. But you will get some people in PDOC who actually look like they have got an adequate pharyngeal swallow, where it's not just purely reflexive behaviours. Perhaps they're licking their lips, they're showing some engagement, some participation. And then obviously we have to think about, okay, I think this person has got potential to have something to eat and drink. What are we going to do? And the absolute crucial message that we would say at this point is to stop and pause. So I think historically, perhaps we used to have a bit of tendency that if somebody could eat and drink physiologically, we would do it. Be like, great, that, you know, that's a positive sign, and we would pursue that kind of quite automatically sometimes. Whereas actually what we need to do is to stop and think about those decisions in the context of the wider sort of medico-legal situation regarding life-sustaining treatments, particularly clinically assisted nutrition and hydration, or CANH, and obviously the individual factors and circumstance for that particular patient. And I'm just going to spend a little bit of time now talking about why we suggest that stop and that pause. So just to talk about the context of decision-making about CANH, first of all, just very briefly. So an individual who meets the diagnostic criteria for PDOC will have such profound cognitive and communication impairments that they will lack capacity to make any care or treatment decisions. And therefore, obviously, all treatment decisions must be made in their best interests as per the Mental Capacity Act. And those treatment decisions apply to CANH because that is defined as a life-sustaining medical treatment. So all patients in PDOC must have a best interest decision regarding starting in the first place, but also continuation of CANH. And it has to take account of the person's current and prior wishes, feelings, beliefs, and values. And for somebody in PDOC, they might not have a great deal of ability or kind of function to have current values, wishes, beliefs, and feelings. So a lot of what we might be basing our decision on will be our consultation of people that know and love the patient pre-morbidly, who can share those things with us and paint a picture of the person. And what we're trying to build up is a picture of the individual and try and establish what would a quality of life that this person would value look like, and what's the likelihood of the person regaining a quality of life that they would value. Some individuals may not wish to continue with life-sustaining treatment in the context of severe and enduring disability, as in the case of the vast majority of people in prolonged disorder of consciousness, whereas other people might have wanted treatments to carry on, regardless of that context. Perhaps they have very strong religious views around the sanctity of life, for example. There are sort of three possible outcomes to this best interest decision making. The first being that CANH continues, that it's decided it's in the person's best interest for that treatment to carry on, in which case it does, with a clear review date, because that might change in the future if the person remains in PDOC for a prolonged period of time and there is no change, no trajectory of improvement, then that the views of the clinical team and the people who know and love that patient might change over time about what the patient would actually want to happen. The second possible outcome is that there's an agreement to discontinue CANH, which will inevitably lead to death of the person. There is quite a rigorous process to go through before actual discontinuation happens, which obviously we won't go into any depth today. It's a whole separate thing on its own. But there's a very rigorous process of checks and balances that happen to make sure that's a really robust decision. But ultimately, if everybody's in agreement, the treatment will discontinue and the patient will die. And then the third possible outcome is that there is a disagreement about what's in the patient's best interests. And that could be between different family members, it could be between the clinical team and family members, it could be between family and friends. So wherever it arises, there's a disagreement there about what should happen for this person. Or the decision could be considered finely balanced. That's also a reason why the decision might need to go to the Court of Protection for the judge to make the final decision. There is very detailed guidance about all of this in the BMA 2018 CANH guidance and the RCP PDOC 2020 guidance, which I've just popped images on the slide there. If you want to read a little bit more. Okay, so let's park CANH for a second, and now we're going to think about oral intake, and particularly what the legal status of oral intake is right now. And I'm going to caveat all of what I'm about to say with a very strong statement that we are not lawyers. We are not claiming by any stretch to be kind of expert on the law around this. There is absolutely a need for more case law to kind of build on our understanding and knowledge as a profession about this, and that inevitably will come, I think. But we wanted to share with you what our understanding is at this time about the status of oral intake in law. So our understanding is that there is a distinction between people who can independently manage oral intake and those who are dependent on another person to support. And where somebody else is involved in the provision of food or drink for a patient, that oral intake, that food and drink is considered a treatment in law rather than a human right, or rather than a part of basic care, which is how historically I think we would all think about it and view it. And I'm sure that many of you are familiar with the case that we referenced there, the JJ case, which obviously caused massive stirs in the speech and language therapy world for anybody working with patients with EDAR decision-making about risk feeding. It obviously has quite significant implications for those decisions, but it also has broader implications because of the additional spotlight it shone on the status of oral intake in law where somebody is assisted. When we're talking about somebody being dependent on another person to support, as in the JJ case, for those who are familiar, that would include obviously feeding somebody, so physically putting the food or the drink to the person's mouth or in their mouth. But we did have a recent non-PDOC case here, where there was some really complex decision-making happening about oral intake and CANH, and the legal team were adamant that assistance to sort of get, to procure and to prepare food also meant that it was care and treatment. So even if this patient could feed themselves, the fact that they weren't able to go to the shops, buy the food, come back, prepare it, sit down and you know, do it all independently, that even that meant that that oral intake, that food and drink would fall under the umbrella of care and treatment in their legal view. I also think it's important to just flag here that the JJ case obviously is just one case, but if you read the case and look at where they drew the kind of the legal principle from, where they said that oral intake, if you are assisted, is part of care and treatment, was from the Anthony Bland case, which is a very well-known case with lots of legal repercussions in healthcare, which was in 1993. And previously, perhaps we were operating in a bit of a grey area where some of this perhaps is not brand new in law, but it just wasn't kind of elucidated before. And a case like this had never gone to court about oral intake with these sorts of decisions. So that's a really important point as well. Another link there beside the JJ case reference is a webinar from the RCSLT, which is a little follow-up that Alex Ruck-Keene, Casey, the barrister, did for the Royal College, following up on some of the questions that were asked as part of a webinar they did about EDAR decision making. And he kind of elucidates that quite clearly about kind of what it means and why and in what circumstances perhaps oral intake could be considered a treatment in law. So if we accept that and we say, okay, if somebody's assisted and they lack mental capacity to make their own decision about this, as somebody in PDOC will be unable to do, then commencing oral intake is subject to the Mental Capacity Act and best interest decision making for those patients, rather than something that should be automatically pursued. We shouldn't just be feeding somebody by default and carrying on with that just because the person can. We need to be stopping and thinking, is this in this person's best interests in the wider sort of landscape of decision making and the individual situation for that patient? Another important question that comes up when you start thinking about these things and in this way is, okay, there isn't a distinction in law between sort of not starting a treatment in the first place and then, you know, withholding it or stopping it down the line. So, you know, there's no legal difference between those two things. So actually, even if oral intake is a treatment, could you start it, see how things go for the patient, and then down the line, stop it if there's a decision down the line that actually this isn't a quality of life the person would value, treatments, sustain them are no longer in their best interest, therefore we should stop everything. So hypothetically, if you're saying oral intake is a treatment, then yes, maybe that would be possible to stop it, unlike when we were thinking of it as part of basic care. But actually, once started, I think this is my personal view, I think it would be very challenging to stop oral intake for a number of reasons. I think it would be even more fraught with really complex ethical, emotional, moral considerations above and beyond those that we already encounter when we're thinking about CAN8 decision making and food and drink through a feeding tube. Okay. So to bring those two things together then, so oral intake decision-making and CAN8 decision-making, they are separate decisions, absolutely they are, but we would say that they are inextricably linked. You can't think about one without thinking about the other when somebody has the potential for ongoing oral intake. So we need to be considering that individual patient's ability to safely manage and possibly enjoy some oral intake, and be considering, okay, if we can start this person having some oral intake, what is that going to mean for this individual? You know, is this going to add to their quality of life, for example? Is this going to mean that maybe they would feel differently about life-sustaining treatments continuing if they're able to eat something? So the implications of starting some oral intake for that person has to be kind of carefully teased out. But fundamentally, when we're thinking about that CAN8 question and that being a life-sustaining treatment, if there is agreement that the patient would not want life-sustaining treatments to carry on. So if everybody consulted, the patient's loved ones are saying, you know, even the best case scenario is not a quality of life this person would want. Even if oral intake was started, that wouldn't change that. We don't think that they would want to continue treatments in a prolonged disorder of consciousness. In that situation, when we're saying the patient wouldn't want these treatments to carry on and we're looking at discontinuation of CANH, it is unlikely to be in the person's best interest to start oral intake, because that would completely fly in the face of the decision about CANH. And if we carry on anyway, because this person, you know, can swallow, can take something, we are potentially closing the door on that patient's opportunity to die, because it might not be that easy to stop oral intake once it's started and been handed over and it is sort of carrying on. Again, at some point, this may well be tested in future court cases. So at the moment, it's a little bit hypothetical. Conversely, if there is agreement that the person would want to continue with life-sustaining treatments, it's more likely it would be in the person's best interest to commence oral intake, or to at the very least explore it further, carefully considering the risks and benefits, as Amy raised, and sort of, you know, thinking about that in the context of the patient's awareness and sort of overall safety, and yeah, whatever benefit it might give to their quality of life, balancing all of that up as a team. So for some decisions around oral intake, you might find that actually it sounds like it's quite complicated, but actually it's quite straightforward, because the decisions sort of follow each other. In our experience, greater challenges have arisen where there's been disagreement about what the person would want. So we might be saying, this person has the potential for oral intake. We need to try and do a best interest decision about what this person would want. And at the same time, we've got a CANH decision where some people consulted are saying, yes, it should definitely carry on, the person would want that. And other people are saying, no, definitely not, the treatment should discontinue, we should let them die. And then what to do is extremely fraught and difficult. And it is likely that legal advice might be required in that situation. About the CANH decision, certainly, because it's disputed, but in all likelihood, your oral intake decision is also going to be disputed, and it should be discussed, you know, as part of that dispute. Okay, I'm going to pass you on to Amy now.
Okay, so I'm also Amy, and I'm going to talk through a case study of a patient who came onto our specialist assessment service, who is a really typical patient that we've been seeing quite a lot of lately, recently, sort of, and how his case sort of reflects back some of the issues that we've talked about. So Mr. M came to us. He was a 58-year-old gentleman, and he had a severe hypoxic brain injury following an out-of-hospital cardiac arrest. So his downtime was 18 minutes. So he had a pretty severe hypoxic brain injury. He came to us from an acute setting 4 months post-injury on our PDOC pathway for specialist assessment and management. An assessment in the acute setting had started for PDOC and indicated that he was in MCS and likely MCS minus, so behaviours such as visual and auditory tracking, but not trying to communicate, not that higher level MCS. Now, he came to us having 2 yogurts a day, so IDSI level 4, and thin fluids. I think it was difficult for us to ascertain quite how much he was having, but it seemed like he was being offered 3 sips of thin fluids, mostly being given by the ward nurses. But we did find that when our nurses tried to feed him, they found it quite difficult. He was keeping his lips closed. Sometimes he would mouth hold, and sometimes he would cough. So on admission to our RHM, we stopped him having this oral intake. We spoke to the consultant. We said, look, you know, he's not managing that well. He's also MCS minus. So we've got this whole ethical landscape in which to make these decisions in. We can't do this in isolation. So we wanted to sort of stop and start again. And I have to say that this is quite a common pattern for us when we have people referred to us and they're perhaps MCS, VS, and we look at them and someone's giving them oral intake. We want to try and get involved as soon as possible to think what's going on here, why are they having it, how's this going to sit with the rest of our decision making. And at admission to our specialist assessment unit, we also have quite a small window for making a decision. Can we maybe pause this because it's not embedded here in our setting, and go back and start again, and therefore involve families in that sort of whole ethical decision making process from the start, particularly if they come in and they're quite low level PDOC, and we really aren't aware of what their CAN-H decision making discussions have taken place. Okay, so Mr. M came to us. We'd paused his oral intake so that we could carry out our PDOC assessments and see, okay, what level is he functioning at? What can he do? So we did the WIM and the Coma Recovery Scale revised, which gave us his PDOC diagnosis consistent with MCS minus. So he was doing some visual and auditory localizing, so following things with his eyes or turning to a sound. And a bit more, he had sort of, he could turn more to the left than the right. He had some right and excited neglect. He had some movement to his left arm, and sometimes he would reach for things. But again, he was localizing. He wasn't using them. He might pick them up, or he might just bring things to his mouth. So he'd bring lots of different things to his mouth. He had no active movement in his legs, and we couldn't elicit any communication behaviours from him. He couldn't follow any instructions, or he wasn't able to make choices or indicate any yes, no in conversation or specific questions. So we decided to include, because he'd been having some taste, and because we do often use taste as part of our awareness assessment, we revisited as part of our assessment process, using assessments of taste to help support our assessment of his behaviour and awareness. So adding to what Amy said, I think Amy went through in quite a lot of detail the findings that you might find using assessment to look at those oral behaviours. And I actually mostly use taste assessment, and I refer to it very much with families and frame it as we're using tastes as an assessment of awareness and for communication behaviours. And I think that helps to set a boundary for we're not looking at eating and drinking with this population. We need to look at it first as what are they doing and how are they responding before we go on to make decisions about eating and drinking. Okay, so what I did was did some work with Mr. M, offering him sort of yogurts. He was opening his mouth to the spoon sometimes, and if I put yogurt on his lips, he would lick it off. So he was localizing again, licking it off. He knew where it was sometimes on his lips. His oral stage was variable. Sometimes it was extended with some mouth holding before he swallowed, but he was able to clear it from his mouth. He didn't have huge amounts left after he had swallowed, and he had quite good lip seal. Sometimes he kept his lips closed, turned his head away. So I don't know if he was refusing or if he just wasn't able to engage, or whether there was some apraxia there, but it was quite inconsistent sometimes how he was able to engage with the task. He showed, quite importantly, so Amy was talking also about bringing in things that people like and dislike. And I do this quite a lot with these patients because actually it's quite telling. So he showed the same response to preferred and non-preferred tastes. So I gave him chocolate mousse, and I also gave him, I often mix up strong coffee granules and give a very sort of concentrated taste of that. And even people who like coffee, really that's not a very pleasant taste. You can do similar with a spoon dipped in Marmite, or find something that they really don't like. And he didn't really respond differently to something that you would expect him to have quite a strong negative response to. He would just lick it off his lips and just proceed as he did for chocolate mousse or yogurt. So given that we know he can reach for items, and that our assessment using tastes is looking at communication and awareness, and perhaps is he able to show us any of these higher level behaviours, I was looking to see whether he could use the objects that we placed in his hand. And sometimes he might bring up the cup or the spoon. He didn't always try and use it, but he would bring it towards his mouth. But remember that he would also reach for other things and bring random things to his mouth, and sometimes just bring his hand to his mouth. I might put a sock in his hand and he would bring that to his mouth. So he's not necessarily discriminating between tastes or between objects. But because he could manage some small amounts, and because we wanted to gather as much information as we could about the safety and potential for ongoing oral intake, we carried out a FEES with him. And that showed us that at a pharyngeal level, he was not at huge high risk on level 4 and level 0. So in summary, all of the behaviours we observed were consistent with his MCS minus diagnosis. But we ascertained that he did have that potential to manage some taste of oral intake. So what could we do next? So we could introduce regular tastes. So he came to us on these regular tastes. And might this get him to practice his swallow to encourage him, to swallow more frequency, or to extend his oral intake? So I would ask with somebody in MCS minus why we would want to do that. Where are we going with that? What are we extending it to? Because he's unlikely to be able to manage enough to meet his nutrition and hydration needs. There are also perhaps other options for practicing his swallow. For example, he'd be having regular mouth care, which would have sort of taste and mechanical stimulation. And he was managing his saliva quite well, so he was practicing swallowing his saliva independently. We can use ongoing tastes for monitoring changes in awareness and communication. So we knew what he could do, we knew how he was behaving. And often I like to see, particularly embedding the communication in there, like, do you want strawberry or toffee yogurt, and offering 2 choices and saying, can you show me if you want more? So you might start to be able to use it for monitoring, not actually taste and eating and drinking, but communication and task engagement. So that is a possibility. And then also you've got the embedded social activity of eating and drinking with family. But is that enough? Because although he's showing some engagement in the actual task, we know that he's not fully aware. He's not discriminating between nice and nasty tastes. And he's certainly not indicating, particularly that he enjoys what we're doing. He is just sort of showing us a bit of participation. So what next? So that's when we hit this pause button that Erin was mentioning. So we know that Mr. M is in PDOC. He cannot make his own decisions. He lacks that capacity. So we need to know, does he want to continue to receive life-sustaining treatments such as CAN-H, knowing that oral intake will muddy that, because obviously he'll be receiving small amounts of nutrition that might get in the way of that decision-making. And Erin mentioned closing that door, but there is starting oral intake could impact on that decision-making window, which Kitzinger and Kitzinger have highlighted. And it really is about, we don't want to point to that. They point to a timeline post-injury when treatment can be withdrawn or not initiated if it's felt that that is what the patient would want and it is in that best interest. We don't want to be the ones closing that window. And the legal tool with which we're working is the Mental Capacity Act. So we really must ask all the time, what is in Mr. M's best interest? What would he want? So really, we are not going to start for him an oral intake trials without a bigger MDT best interest decision. Okay. So this starts as well alongside our admission. I've talked about he came to us as SLTs, we paused his oral intake, we carried out our awareness assessments, and we brought back tastes as assessment of awareness. But alongside this, we work very closely with the family. So we have a family meeting here 2 weeks after admission, and the doctor discussed treatment escalation planning. So this includes CPR, this includes other treatment escalation plans about admission to acute settings, et cetera, and also we start the discussions about, would Mr. M want to carry on accepting the treatment of clinical assisted nutrition and hydration? The doctor at that point raised the method of injury. So remember that Mr. M has got a hypoxic injury, and the prognosis for him, given that he's currently MCS minus, is that that would be considered permanent 6 months post-injury, and he's already 4 months post-injury. So we're not anticipating perhaps huge amounts of change. We found out quite early on that even though he'd been admitted to our level 1 sort of assessment service, his wife, children and siblings all agreed he would not want to be like this. His mum had had a stroke and gone into a nursing home, and at that point he'd said quite clearly, I'd never want to be like that, I don't want to be in that position. He was fiercely independent, still working as a partner in an accountancy firm, and he had a very active lifestyle. So we knew that he liked going to football matches with his son. He had a season ticket, and his young adult son used to go with him regularly. He played five-a-side football himself once a week. He was on a pub quiz team. He liked to participate in that with friends. We know that from his family, that he would hate to be dependent on others. And quite interestingly, they said to us, he wasn't a foodie. He ate to live, but he didn't live to eat. And in discussion about, would having small amounts of oral intake change that decision? Would that make him maybe want to be here a bit more? Is that enough of a quality of life? They felt very strongly, his family, that that wouldn't be enough for him in the context of his wider disability and the prognosis. Okay. So towards the end of his stay, as we completed his assessments and had these ongoing discussions with family, we had a robust best interests decision. We carried out this robust best interest decision-making process led by the consultant on the ward. So the role of the SLT here was to communicate our swallow assessment findings alongside our awareness and communication findings. And it's also our role to put forward, in our view, what would be in his best interest as part of this meeting that we had. And as an SLT, it was felt that he could manage oral intake, he engages with it, there's no clear enjoyment, no differentiation, and that all the people that the SLT had spoken to and who knew him felt that he wouldn't want the treatments to continue because oral intake wasn't enough to sway this for him, to make his quality of life enough that he would want to continue with CAN-H. So in this case, everybody agreed, the clinical team, the family, and we also spoke to 2 of his friends as well about, because they know him differently from family. And part of the guidance is that we speak to as wide a circle as possible. So it was decided that he really wouldn't want to continue with his CAN-H, and therefore it was discontinued, which meant that we didn't start oral intake because it was not deemed to be his best interest because of that discontinuation of his clinically assisted feeding. So we were lucky in that case because actually the family and the friends, they all agreed, they all knew Mr. M really well, and they all agreed that he would not want to continue. But obviously we come across cases that aren't so clear cut. But what we wanted to do was give you an example of when everyone agrees and when you follow the process, this is how it can be. But we've come across many cases where family don't agree and it's not straightforward. And also cases where it's not dissimilar, where people aren't actually in PDOC. So although we don't have a obligation to bring it up and ask people about CAN-H, families are bringing it to us in patients who do not have capacity but are not in PDOC. Okay. So we're going to end our presentation there, and the 3 of us are around. I think there are quite a lot of questions in the chat.
Yeah, there's some juicy ones.
Okay.
Shall we
Let's
put it in the
pop it
middle
there, yeah.
and then we can put it back in? Alrighty, Amy, squidge in. Squeeze in. Okay, so thank you to those who've been adding some questions into the chat. We have been compiling them. We've had quite a few kind of a cluster around sort of acute decision making. So things like, would it be appropriate for speech and language therapists in CCU or on acute wards to have conversations with families about best interests? And they said, to save you at rehab from ceasing the oral intake and starting again. Would you prefer acute settings, this is somebody else, not to start oral trials with these patients before coming to you? Does it make it harder for you when you get these patients? And another one, do we need to be having these conversations in the acute setting? We have difficulties asking consultants to paint how the future may look, especially with families, I think, they were saying. Yeah, that was a little bit.
So should we answer the acute?
Yes, yeah. I mean, I think we would say that certainly in terms of whether you should be having conversations as an acute team about best interest about these patients, absolutely 100% yes. I think we appreciate that that's very easy to say. And we as AHPs, we as speech and language therapists might have a very clear idea in our head potentially about, you know, what we should be talking about in terms of best interest decision making. That isn't always a shared platform to be working from with some of our MDT colleagues. You know, it's going to be the consultants, it's going to be the doctors who are the decision makers, and we fully appreciate that there can be challenges there and sort of being on the same page with some of these things.
So I'll talk about, would we prefer acute settings not to start trials? Sometimes yes, quite frankly, because it becomes very muddy for us if they come to us with a low-level PDOC diagnosis or regular oral intake. It doesn't quite make sense or match up. But what I would say is don't start oral trials, but definitely, as I was saying with Mr. M, use tastes and frame it very much with family that are MDT. I'm using tastes, so you're not using oral intake, you're not using eating and drinking. I'm using tastes to assess for awareness and communication. So you frame it slightly differently. So you're looking at, do they localize? Do they respond differently to different things? Can they indicate from a choice of 2? Can they show you they want more or answer yes, no questions in a motivating context? but don't frame it as oral trials and oral intake. So that way you can do a bit of both, but it still means you have to do that pausing. So you can then just use it for your assessment and contribute to where you think they are and what potential they might have. But you still need to stop and do that thinking with your team about, well, okay, but where's this going prognosis wise, and where's this going if we admit them to a level 1? Because quite often we do have to unpick decision making from acute where they come in with substantial oral intake and it just doesn't make sense, and we don't have a best interest decision. And we might even have a family member saying, well, actually they wouldn't want to be like this, but somebody started them on 2 yogurts a day, which makes it harder.
Or
because
more,
yeah, or more. And as Erin was saying, even though in these cases that oral intake can be considered to be a medical treatment, it's going to take a lot of perhaps more court case studies before people are going to feel confident to stop that oral intake. So it's just best for it not to start so robustly in the first place, I think.
Yeah, I think we've kind of broadly answered that. If a patient is transferred to a community setting, for example, a nursing home, how might oral intake trial for PDOC carried out, or would this need to occur in a hospital setting? So I think you absolutely could use this in the nursing home. It's exactly the same as Amy's just suggested in terms of you're using tastes as part of your assessment of awareness. You're not doing it with the purpose of starting oral intake with an aim to kind of pursue it and ramp it up and increase it and take it forward. Yeah, and there's no reason why you can't do that. It might look a little bit different in a nursing home in terms of, what MDT you've got around you, and those sorts of things. But yes, you can use taste for assessment. Can acute settings ask you questions about a patient to help with starting oral trials? So if you're stuck, yes, people do get in touch with us and email us or ring us.
Please do.
If you have patients in this kind of circumstance where you're a bit stuck and you want to kind of pick brains, we're happy to take emails and phone calls as a team to support with that if we can help. Somebody else has said, this is quite a long one, hi, I work on intensive care where I'm involved with patients when it's too soon to determine what level of recovery they'll be. There is an emphasis on assessment and rehab ASAP. This has led to issues further down the line when a patient has been started on oral intake, but then it has been stopped following transfer. As a team, we've had discussions about our management around this. Are there any guidelines around this for assessment and management in the intensive care setting? How can we manage swallowing when it is unclear at that stage of prognosis? I don't think there are any.
I think it's the same.
Yeah.
You can use tastes for assessment and monitor. But then you can also do other things. You can do, people are having toothbrushing several times a day, which is sort of oral stimulation. It's got mechanical stimulation, taste stimulation. Are people swallowing their saliva? Can you use oral stimulation routines and FOT routines to improve swallow frequency or reduce hypersensitivity? And very much just focus on using tastes for assessment of awareness. And if you frame it like that, I think you're still providing that rehab, that opportunity, but you're not starting full on oral intake and food and eating and drinking until you might have a family right from the very beginning that would say, you're never going to turn the machines off. He would want to be a fighter. He's got a really strong faith. So you might have a good inkling there that maybe they are never going to remove CAN8. So in fact, you still have to look at your individual right from the beginning, be discussing with families and hopefully with the rest of your MDT, where's this going? And I guess in ICU, teams are used to making these decisions and sort of life-sustaining treatment. It's just perhaps not in this population in the same way.
And they're perhaps not used to thinking about oral intake as part of that best interest formulation. So maybe sort of, having some dialogue with some of your MDT colleagues about, about that, kind of starting those conversations.
The only other thing I was going to add is just thinking about, I know it's saying about kind of assessment and rehab. If someone's in PDOC and they're coming to a level 1 unit, they're coming to an assessment unit. So they're not coming for kind of rehab per se because they can't engage in it. So it might be a helpful way to frame it. And actually they want you to look at oral intake. Okay, well, you're starting the assessment there in IT, you're getting that information, you're fact finding ready for when they may come on to us. And we're then kind of given a bit of baseline information as opposed to framing it as rehab. Think about it kind of an earlier start of that assessment process, which also would be really helpful to us.
So actually these patients come to us on our PDOC pathway, not on our rehab pathway, because in order to participate in rehab, you need to be able to participate in goal focused sort of activities, which these patients almost by definition can't. So that's quite helpful.
Okay. Okay. I'm in the same situation as Madeline. I'm in a acute setting where it could be too early to be having these discussions. I think my personal view on this is that it's never too early to be sort of framing these discussions with families. And actually, what can be really challenging is when, you know, families down the line come to a setting like ours, for example, and we are raising, you know, CANH decision making, and they're not even aware that feed and fluid through a tube is a medical treatment, and that there's even an option for that potentially to be, you know, either continued or discontinued depending on best interest. And that can be really, really difficult. And I think it is improving, it's getting better. So more families are arriving with a clearer idea about what treatments their loved one is receiving, so that they're more prepared to participate in those best interest discussions. But I think, you know, it's vital that we have these discussions, and all that we can do is just be honest. It is quite early, you know, they're in ITU still, it's only been a few weeks. We don't know, you know, what this is going to look like. And it's the same in our level 1 unit. Quite a lot of the decisions in best interest around CANH and life-sustaining treatments are to continue because it hasn't been that long, and the sort of best interest formulation is that the person would want a little bit more time to see what changes them, if anything does change. And that's the decision with a very clear review date. So it may well be that in intensive care setting or an acute setting, even more likely that your decisions are going to be to continue, because you want to give them the opportunity to go to rehab for this period of assessment and optimization, to see if there's any trajectory of change, to better formulate a prognosis to help guide best interest decision making. But you know, it really has to start, in my view, at that very, very beginning stage.
There's a question here. Can we have an assessment period of oral trials of longer than a few weeks?
If a person's making progress,
yeah, I mean, it's that
too early.
And monitoring, isn't it? It's just using that same approach, but not handing over to a ward, not starting them on several times a day. It's going back as an SLT and seeing if there's change, seeing what they're doing, seeing how their awareness and communication is changing, and then putting all of that into the context of the decision making.
Yeah. Somebody else asking, we've just recently gone through a withdrawal of CANH process and wondered if you got a second professional opinion despite everyone being in agreement. So yes, in the BMA 2018 guidance, it does set out really clearly the different sort of patient groups that guidance covers. It specifically signposts you to what the level of scrutiny needs to be of the decision. And for people in PDOC, it's really clear you have to, even if everybody's in agreement that treatment should stop, you have to have a second opinion from ideally an independent consultant. If the original consultant, the original decision maker for the decision to discontinue was not a PDOC specialist, then the second opinion has to be a PDOC specialist. So yes, definitely, we always have a second opinion for any discontinuations of CANH. Another question here. Are your concerns around oral intake that starting this would extend someone's life? Would we be expecting people to have enough orally to maintain adequate nutrition or hydration? I think I said, yeah, so if you, like Amy referenced, if you've started somebody on some oral intake and they're having something regularly, be that, you know, sips of fluid, a couple of yogurts a day, tiny portions of puree, whatever it might be, and then you're talking about CANH decision making and talking about, would this person want this treatment to carry on or discontinue? If it seems to be going down the road of discontinue and you've started oral intake, it's not massively clear cut, I think it's fair to say, legally, where you stand in terms of stopping that oral intake. If it's something that's established, the person's having on a regular ongoing basis, it very much muddies the water. So actually it's much preferable to be sort of stopping and pausing and thinking about these decisions, as I say, as linked together, rather than separately and doing sort of one and steaming ahead with it when you haven't got the other. They're sort of they need to speak to each other in terms of that decision making. Does that make sense?
Yeah.
Yeah, and there's someone else, Sally, so that's really reassuring, saying that she works in a level 1 rehab and she does stop oral intake for formal PDOC assessment, particularly at low level. And I think that's what we do, but it's just we need to perhaps stop and think before they get to us in level 1, whether they should be started on it, because it's really about managing family expectations sometimes as well, particularly if the CANH decision hasn't been brought up with them.
Someone else saying, I'm seeing a PDOC client in the community. He was seen previously by an SLT in the trachea team who was doing oral trials with him with the goal to remove his trachea. Now that the trachea has been removed, he is coming to our rehab team. I'm aware he currently shows no preferences in tastes and no enjoyment. What would you recommend next?
If he's still PDOC, if he actually is PDOC, it would be helpful to know whether he's been having, because if he's in the community, he should be having annual reviews around his PDOC status and his best interests. So it'd be good to have that as a background to know actually what discussions have ever had, if they've ever happened.
I think should be is quite
yeah.
we know that a lot of people
we know it's not, but I think
there.
I would start there with some fact finding to see actually has there been discussions before around an acceptable quality of life to this man, because now his trachea's out, so that's different. That could be very important. That could have changed his what his views would be. And then do the assessment period, like we said, and just document it. And then that's your information that then you will be taking to the best interest meeting. I've assessed him for this amount of time. This is what I've seen.
Yeah, here's my risk benefit formulation. You know, he doesn't seem to be, if it's the same picture that you've been told about, that he doesn't show any preferences, he doesn't seem to enjoy it. If you think that he's relying on reflexive behaviours only, you know, the risks are likely to be quite high for somebody in that circumstance, and the benefits really very low. You know, so it's obviously coming up with that risk benefit formulation to, as Amy says, to take into that best interests discussion.
And I think the thing is, just because his trachea is out doesn't mean that his swallow, I mean, his pharyngeal swallow may be pretty good on his saliva. It still may be crap on food and drink, but it doesn't mean that necessarily he's going to be a functional eater just because his trachea is out. And I think sometimes that gets stuck a little bit. We think, oh, well, they've got their trachea out, or now we'll move them on to the next part. Actually, there may be no moving on from this.
Someone else, do you ever have scenarios where commencing oral intake may not be in best interests, but continuing with CANH is, and how do you manage these situations? We have had...
Yes, because they come to us and we don't want them to have oral intake because it muddies the water, but they might have their CANH, as Erin mentioned, because they're still relatively early days and you want to give them a chance for assessment and monitoring to see where their trajectory of change might be. So in fact there you might say, well, yes, we'll continue with the CANH because that they need to have that opportunity really, but we won't start regular oral intake until we've maybe completed some of our discussions with family about what they would have wanted. So it could be that it's more of a delaying, and you work out before, you know, you spend some more time getting to the bottom of what the patient would want.
And then in that gap you could do the alternatives. So you could look at things like Biozoom, you could look at FOT, you could look at your mouth care, and you can still be doing it in a way that is optimizing the patient, and you're taking a good record of what they're doing and how they are or aren't changing. So it's not wasted time. I think sometimes people think it's kind of wasted time. It isn't wasted time. It's still a really important part of your monitoring. And ultimately, if they're PDOC patients, they're not kind of rehabbing anyway. So you're not missing out on things necessarily.
And we did have, I'm thinking of a particular patient, we had a patient who had some lasting powers of attorney for health and welfare, who were therefore the decision makers, and the end decision for that particular lady in PDOC was that she wouldn't start. She had the ability to eat and drink. It wasn't purely reflexive. She was demonstrating some awareness of the bolus, some enjoyment and engagement with it, but they decided that it wasn't in her interest to kind of go down that road now to start oral intake. They wanted her to be discharged to her kind of long-term nursing home setting to see how she adapted to that environment, what her quality of life looked like in the longer term, to basically to leave the window open, as Amy spoke about, so that down the line, if they felt that actually on balance, it's been another 3 months, another 6 months, she hasn't changed, you know, she wouldn't want this, that the option is still there to discontinue CANH and allow her to die, rather than, you know, starting the oral intake and going down that road too far and that window being inadvertently closed for that lady. Do you have any tips for biting? If a spoon cup toothbrush is bitten, how do you get it out without causing damage?
Okay. There are things you can do.
Don't pull it.
It's not quite part of it's linked to this, but so things like trying not to present the spoon from the midline, not using a cold metal spoon, present it from the side, allow time, don't put it out because it's going to get more of a bite. And you might need to do some oral stims, try and break that bite. But yeah. if it's a persistent problem, you probably don't want to be putting spoons in cups.
Exactly. Just be really mindful of what you're putting in there in the first place, I think is the best tip. If you know that somebody's got a really strong bite response, be super careful what goes in there. Is it an SLT role to discuss CANH as a treatment, or is it a medical team or dietetics role? It's absolutely fundamentally the responsibility of the person that's prescribing that feed. So ultimately responsible would be the medical doctor, the GP, the consultant, depending on where they are, responsible for that patient's care and treatment. The dietitian also has a responsibility because they're writing in the notes, prescribe these feeds. This is the in the person's best interest, for these people in PDOC. So definitely they have a responsibility. Recent court cases have highlighted that, the ICBs have a responsibility. So the ICBs have a responsibility to make sure that any environments, any nursing homes out there that are caring for people in prolonged disorders of consciousness, that they are asking the best interest question. So no, it's not a sole SLT role. I would say any AHP though, we have a level of professional obligation, I guess, that if we are seeing a patient and we become aware that, there are best interest discussions haven't happened when we know that they should have happened as per the Mental Capacity Act, which is the legal principle underpinning all of this, then I would say we have a responsibility to raise that. But fundamentally, the responsibility doesn't sit with us, but we may be part of that consultation, maybe asked to give a view on best interests if we're working with that individual.
I think there's a question here about using fees as part of our assessment, and I think that's okay, because I think what we're doing with our assessment of awareness, our assessments of tastes, and if somebody is a bit higher level, perhaps MCS plus, and there's sort of conversations in the background about whether they would or wouldn't want to carry on with the CANH, you basically use fees as part of your risk assessment. You're gathering as much information as possible to weigh up the risks and benefits, because actually if the swallow is really risky, that gives you quite good information. So Mr. M, we did a fees on him because he was, he came into us having some oral intake, and we wanted to be able to say to family, look, this is how much we might think he'll get. This is the sort of or potential with oral intake. Is that enough of a quality of life for him? So that fees would help you to inform that. Because if oral intake is making him cough or is silently aspirating it all, then it's not really contributing to any quality of life. But if you find that he's managing, then it gives you more information for those discussions, I think.
Absolutely. Catherine's asking, hi, do you accept patients with trachea into a level 1 PDOC service? Yes. Do you always complete objective assessment before trials / assessment, i.e. fees? No.
We just do it at bedside. When you say oral assessment before trials, we're doing small amounts, because remember we're assessing for communication and awareness. So we're not giving huge boluses. We're using coated teaspoons, dipping fingers in a flavour of drink, maybe a small sip. We're not going out with eating and drinking. We're going for awareness with taste. So actually we don't need to do objective assessments, because we're, like I say, you might do a fees if there's the potential to carry on, because then you want to look at risk benefits. But initially you don't need to. You need to just look at how they respond functionally.
Okay. What are the main characteristics to recognise between a reflexive swallow, i.e. movement with gravity, and a full bolus swallow? I think they're asking sort of what would we look for that tells us something's reflexive versus something that's not reflexive. I think that slide that you shared, so the slides will be shared, is really helpful in that. So it breaks down kind of what behaviours you might see for somebody who's in a vegetative state, what behaviours you might see somebody who's in MCS. I think, the reflexive responses we see.
The oral behaviours that you're looking for are going to tell you more about cognition.
Yeah.
So that's it when you
pre-oral,
pre-oral. That's what we're looking at with our swallowing. We're not just looking at pharyngeal swallowing, we're looking at the cognitive behavioural aspect of swallowing and the physical side of swallowing, which is, so it's about all those pre-oral behaviours, oral behaviours, manipulation, anticipation, and I think it's, fair to say that you can, as part of your assessment, we don't give a lot because it's not always indicated, but we would sort of try and challenge a patient. So we would sort of try and give them, a spoon load full and say, actually, do they start to move things around their mouth? We might give them some food mash to see if that elicits anything else. So you still need to do the same way that you would do with your normal swallow assessment. You still need to look at all of your stages of swallowing and then try and map that onto what you're seeing.
You might do things like, I can find myself smearing yogurt on people's lips to see, are they aware of it? Do they lick it off? Do they respond like you would? Like
licking your lips is not a purely reflexive movement. So put big blobby yogurt on and the person licks it. It's localizing, it's a more intentional, purposeful type response.
Yeah.
But say Amy's got a really good slide that will show.
And looking at what they do
later.
at rest is the other thing. So doing that comparison of kind of baseline behaviours versus behaviours with a stimulus is really, really important.
I think Rebecca is asking, do we need to be saying they're coming to you for further assessment rather than rehab, which our doctors love to say?
Yes,
Yes, please.
Yes. On the
Absolutely,
PDOC
yes.
pathway for
Yeah.
specialist assessment and management.
Yeah, the assessment and disability management, because they cannot engage in rehab because they aren't aware of themselves or the environment. So if you're not aware of yourself or your environment, you cannot be aware of what others are doing to you, which is how you learn.
Absolutely. I think that is all of the questions that we have received.
Anna, can you push that?
Can we far away now for us to reach it? Or we can stop sharing.
No.
Oh yeah.
So we hope that you found that useful. I think somebody asked if we mind people contacting us. We don't, so that's fine. You can get hold of us here, drop us an email or give us a ring, and we can sort of provide sort of some specific information about patients if you're in acute setting, for example, or just guidance. Before we finish, I'm going to do a shameless plug. Amy touched on emergence and some of the controversies about assessing for emergence. I've just completed some studies, some PhD study looking at that in particular. And again, as SLTs, I'm aware there's a lot of SLTs on the call. We have that specialist role in assessing communication and trying to determine if someone's emerged. And I've gathered we're having a conference in October, and there's some other researchers sort of from America and from Copenhagen who are coming over, and we're talking about how can we look at conversation and communication in emerging patients in a different way. So that's just a shameless plug there. And lastly, we'd love your feedback. So we've got a QR code here, so just have a...
Yeah, completely. It's very brief, but it's just hopefully helpful, and then we can make sure that anything else we're offering in future is relevant to what people want and are interested in.
Yeah, absolutely. And any feedback, this is the first time that we've spoken about this specifically in this way, so actually it'd be really helpful, whether it would be useful to you in practice, and any sort of tips or things that you'd like us to expand on in future.
Okay. Thank you for giving up your lunch times.
Yeah, thank you very much, everybody.
Thank you.
Bye.